Hello, good evening, guys. How are you? Hope I'm audible. Please write in the chat box. Hello, guys. So we'll start this session of one-liners of anesthesia. There's my Instagram ID also. If you're having any doubts, you can just post it on the ID or you can ask during the session also. Right, guys? So basically, in this one-liners of anesthesia, we'll be discussing some 60 questions, but which will cover almost all important topics of anesthesia. Okay, so it's just not 100 things that have been covered or 100 one-liners that have been covered. It'll basically cover almost all of the subject of anesthesia. Okay, so once again, this cannot replace the whole anesthesia content which has been taught to you in 22 hours or 24 hours. Okay, it is just a brief thing. So guys, starting with this one-liner session, right now it's looking someone is replying. Okay, good evening. Okay, starting with the session, guys. Starting with the first thing. Come on, guys. What is being performed in this picture? And when was this performed? What is being performed in this picture? It is basically, come on, any answers? In this picture, what is being performed? Right. In this picture, there is public demonstration of ether anesthesia. Public demonstration of ether anesthesia. By whom? By W.T.G. Morton. And when was it performed, guys? It was performed on 16th of October, 1846. 16th of October, 1846. Hence, the 16th October is also celebrated as World Anesthesia Day. Very good. Okay. World Anesthesia Day. Okay. Right. Coming to our next question. Which Mallampati classification this patient belongs to? Patient came to your clinic. He's opening his mouth. You are able to see this picture. Come on, guys. Please answer. Which Mallampati classification? Remember, Mallampati classification plays an important role in airway assessment. Very good. This patient belongs to class 4 Mallampati. How can we say it is class 4 Mallampati? Remember, guys, when he's opening his mouth, I am able to see only the hard palate. Only hard palate is visible. That is class 4. Okay? Basically, in the pre-anesthetic checkup, we do an airway assessment in which one of the most important tool is Mallampati classification. Very good. Just I'll briefly brush you through up this Mallampati classification, guys. When do you call it as Mallampati class 1? When the patient opens his mouth and you are able to see the hard palate, you are able to see the soft palate, you are able to see the base of uvula, you are able to see the uvula, you are able to see the tip of uvula and tonsillar pillars. Basically, all structures seen class 1. Okay? That is class 1. Class 2 means without the tip of uvula, the structures that you see in class 1 without tip of uvula, that comes under class 2. Without tip of uvula, that comes under Mallampati class 2. Mallampati class 3 means hard palate is visible, soft palate is visible, and base of uvula is visible. Base of uvula is visible. That is class 3. Class 4 means only hard palate visible. Remember, guys, class 3 and class 4 are the cases of difficult airway. Why? Because we cannot put the laryngoscopy and we cannot do intubation in these two classes. Okay. So that is Mallampati classification. Okay. Now, next question, guys. Clopidogrel needs to be stopped how many days before surgery? Clopidogrel is a tablet which is basically an antiplatelet tablet. This has to be stopped how many days before surgery? Come on. The correct answer for this is very good, very good. Some say 1 week, some say 8 days. You can just remember clopidogrel has to be stopped 7 to 8 days prior surgery. In emergency scenarios, you can continue it. In emergency, you have to take the patient on clopidogrel, but you have to arrange for the blood transfusion. You have to arrange for the platelets and all. Okay. So, but we are talking about elective case. Elective case 7 to 8 days before surgery. When there is a point of clopidogrel, we also need to remember what are the drugs which are stopped before surgery and what are the drugs which can be continued before surgery. Remember, guys, the medications that needs to be stopped remember guys, 7 or 8 days, clopidogrel, right? Right. The medication that need to be stopped before surgery is monoamine oxidase inhibitor. Monoamine oxidase inhibitors, they has to be stopped before surgery. Okay. For that, there is a mnemonic, guys, which I developed. Okay. There were many mnemonics developed by me, but this mnemonic is usually fitting and we'll easily remember it. Remember, before taking the patient into the operation theater, we tell the patient to change off your home clothes and take the hospital clothes. Yes or no? So you need to remember the drugs that need to be stopped before surgery are nothing but you are telling the patient to stop. Yeah, you are telling the patient to not to wear his clothes, right? So you need to remember what are the medications that need to be stopped. My clothes has to be stopped before surgery. My clothes, you have to remember before surgery, the home clothes are usually off. M stands for monoamine oxidase inhibitor. That has to be stopped 3 weeks prior surgery. 3 weeks prior surgery. C stands for, just now we have discussed, clopidogrel. That has to be stopped at least 7 to 8 days before surgery. Okay? L stands for lithium. Lithium has to be stopped at least 24 to 48 hours prior surgery. Why? Because if you give lithium and you give muscle relaxant, lithium will prolong the effect of muscle relaxant. Okay. Apart from lithium bottles, we need to remember, guys, we need to remember O. O stands for oral hypoglycemic drugs. That has to be stopped on the day of surgery. On day of surgery. T stands for tricyclic antidepressants. They have to be stopped 3 weeks prior surgery. 3 weeks prior surgery. Okay? H stands for heparin. Heparin has to be stopped at least 6 hours prior surgery. And S stands for smoking. Okay? I tried to incorporate most important drugs, guys. Apart from that, if you want to remember, you can also remember warfarin is also stopped. Okay? But in this mnemonic, warfarin was not fitting, but you can remember like this. My wonderful clothes. My wonderful clothes were stopped before surgery. Wonderful, W stands for warfarin, guys. Okay? W stands for warfarin. Okay? So these are the drugs which are stopped. And what are the medications that can be continued without causing any problem, guys? All active agents are always given. Basically, meaning what? Antihypertensives can be safely given on the day of surgery, except of ACE inhibitors and ARBs. ACE inhibitors and ARBs are usually stopped on the day of surgery. Okay? Rest all antihypertensive medications can be safely given. Next, A stands for anti-anginal medications. Anti-anginal medications can be continued. Next, A stands for anti-lipidemic or dyslipidemic drugs. Atorvastatin, rosuvastatin, they can be continued before surgery without any problem. Okay? Next, A stands for anti-epileptic medications can be continued. And last, A stands for anti-thyroid or euthyroid medications should be continued. These are the medications which can be safely given without any problems. So what are the medications which are stopped before surgery? My clothes are usually stopped before surgery. And what are the medications which are continued? All active agents are always approved. Okay? These will cause no problem, but stopping this will cause some problem. Hence, they are usually continued before surgery. Okay? Right, guys. Next, what is the fasting guidelines for adults? Come on, guys. Fasting guidelines for adults. You tell the patient to be in a fasting state so that the patient during surgery, he do not aspirate. Okay? To prevent the risk of aspiration, you tell the patient to be in a fasting state. So in adults, what is the fasting guidelines? I have written 862 for adults. What does it mean, guys? Come on. 8 hours for, very good. 8 hours for solids. If the adult is on solid food, 8 hours of fasting is needed. If the adult is on semi-solid food, how many hours of fasting is needed? For semi-solid, 6 hours. Whereas if the adult is on liquid, 2 hours of fasting is needed, right? Remember. Now for pediatric age group, we follow this 2, 4, 6. Remember, 2 is common between adults and pediatrics. 2 is common, 2 hours of fasting if the child is on liquid diet or water. Juice without pulp also comes under liquid. Okay? 4 hours of fasting is needed for pediatric age group if he is on mother's milk. Okay? 6 hours of fasting is needed if the baby is on formula feed. Formula feed. Okay? So this is regarding the fasting guidelines. Fasting guidelines in adults as well as pediatric. And you know, why do we keep the patient in a fasting state? To prevent the risk of aspiration. Now guys, you have done your PAC. Now you are giving a certificate to a patient that you are healthy enough to go under surgery. To go under anesthesia. That certification is called as ASA certification. Now, according to the ASA, when is the patient called as ASA class 4, guys? When do you call a patient as ASA class 4? Come on. Which patient is called as ASA class 4? First of all, we need to understand what is ASA class 1. ASA certification depends upon the systemic illness the patient is suffering with. If the patient is not having any systemic illness, patient को कोई systemic illness नहीं है, यानी कि वो belong करेगा ASA class 1 को. That patient belongs to ASA class 1. ठीक है? So ASA class 1 means patient free from systemic illness. ASA class 2 means patient having mild systemic illness. Patient having diabetes, which is well under control, it is class 2. Class 3 means patient having moderate to severe systemic illness, which is not under control. Moderate to severe systemic illness, which is not under control. Uncontrolled diabetes, uncontrolled hypertension. ASA class 4 means, the question was, patient is belonging to ASA class 4. What does it mean? Very good. Patient suffering with life-threatening systemic illness. Patient suffering with life-threatening systemic illness. Okay? Remember, guys, diabetes is not that life-threatening. Hypertension is not that life-threatening. But if the patient is telling, doctor, I had an MI 2 months back. Doctor, I had a stroke 2 months back. That is a life-threatening thing for the patient. Okay? So patient having any life-threatening systemic illness, that could be, example could be a recent MI or recent stroke. Okay? Class 5 means what? Moribund patient. Moribund patient. Multiple comorbidities he is having. Without surgery, there is no survival chances. That is class 5. Class 6, when do you call? Class 6 means a brain dead patient. Class 6 means brain dead patient. So our question was, the patient belonging to class 4 means what? Patient is having a life-threatening systemic illness. He belongs to ASA class 4. ASA is a certificate that you give in the PAC as the last thing. Okay? Chalo. Coming to the next question. What is the main mechanism of action of local anesthetic? Remember, guys, local anesthetics are the drugs which are given in spinal anesthesia, epidural anesthesia, in all anesthesia techniques, nerve blocks, every anesthesia techniques, except general anesthesia. Now, whenever you give a local anesthetic, what is the main mechanism of action? It goes to the nerve. Okay? This is the nerve fiber. When local anesthetic enters the nerve, remember, the non-ionized form of local anesthetic enters the nerve and then it becomes ionized. And that ionized local anesthetic, what does it do, guys? The main mechanism of action is what? to block the sodium channel. So what is the main mechanism of action? Block the sodium channel. Once the sodium channel is blocked, depolarization is blocked, okay, action potential is blocked, and there is no pain. So the main mechanism is blocking the sodium channel. Now, these local anesthetic drugs are classified into two categories. You might be knowing those categories. What two categories am I talking about, guys? Amino ester, amino amide. When do you call a drug amino ester? When it has one alphabet of I in it. When do you call a local anesthetic amino amide? When it has two alphabet of I in it. Okay? Examples of amino esters. Examples: cocaine is there, procaine is there, chlorprocaine is there. Okay? Cocaine, procaine, chlorprocaine, benzocaine, tetracaine, all are having one I's. Just you have to remember one I drug, amino ester. Remember, in these amino esters, which was the first introduced local anesthetic, guys? The first introduced local anesthetic was cocaine. Nowadays, this is just an abuse drug. Okay? Cocaine. Okay? Cocaine. But remember, what is the side effect that you see with cocaine? Cocaine causes severe, or it is a potent vasoconstrictor. It is a potent vasoconstrictor. Hence, cocaine should not be given IV. Hence, cocaine should not be given IV. So these 2 points of cocaine that you have to remember. Okay. Amino amides means what? The drugs having two I's. Lignocaine, prilocaine, bupivacaine, mepivacaine, dibucaine, all are amino amides. All are amino amides. Okay. Now, related to the local anesthetic, we'll solve some of the one-liners, guys. Which is the longest acting local anesthetic? Which is the shortest acting local anesthetic? Which is most commonly used local anesthetic? And which is the most cardiotoxic local anesthetic? Okay. If you want to remember all these MCQ in one line, you have to remember one small thing, guys. Okay. Remember this thing. Delhi to Bombay loves Priyanka Chopra. Delhi to Bombay loves this actress Priyanka Chopra. Okay, why am I telling you is basically when you want to write which is the longest to shortest acting local anesthetic, the mnemonic that we need to remember. Guys, remember before exams, these mnemonics will be of much use. Delhi to Bombay loves Priyanka Chopra. D stands for the longest acting is dibucaine. Shorter than dibucaine is tetracaine. Shorter than tetracaine is bupivacaine. Shorter than bupivacaine is lignocaine. Shorter than lignocaine is procaine. And amongst these, the shortest acting is chlorprocaine. So first question was, which is the longest acting local anesthetic? You got your answer. The longest acting local anesthetic is what, guys? It is the dibucaine. Which is the shortest, guys? It is the chlorprocaine. Now, which is the most commonly used local anesthetic worldwide? Most commonly used local anesthetic worldwide is lignocaine. Okay? Which is the local anesthetic that causes cardiotoxicity? Local anesthetic causing cardiotoxicity is bupivacaine. Bupivacaine is the most cardiotoxic local anesthetic. So Delhi to Bombay loves PC, right? Dibucaine, tetracaine, bupivacaine, lignocaine, and procaine and chlorprocaine, right? So with this, we have covered 3 to 4 MCQs. Now, guys, in this, 2 drugs are very much commonly tested. One is the most commonly used local anesthetic in all techniques, that is lignocaine. Other one is the second most commonly used local anesthetic in techniques, that is bupivacaine. Bupivacaine, you have to remember, it is the most cardiotoxic. Now coming to lignocaine, guys. Lignocaine is the most commonly used local anesthetic. Okay? It is the most commonly used local anesthetic worldwide. Okay? Apart from that, lignocaine is most commonly used local anesthetic in a technique called as IVRA. Heard about IVRA? IVRA is nothing but intravenous regional anesthesia, which is also called as Bayer's block. Okay. Apart from that, lignocaine is the most commonly, or lignocaine is the lignocaine is which commonly causes malignant hyperthermia. Malignant hyperthermia. But how to remember this, guys? With this spelling of lignocaine, you can remember these three important MCQs. The first L of lignocaine means it is a local anesthetic which is most commonly used. It is a local anesthetic which is most commonly used. With this I of lignocaine, you have to remember lignocaine is the most commonly used in IVRA. So with LI, you can remember this. With this G, remember G stands for Garmi. Garmi means temperature is high, hyperthermia. So remember, lignocaine is the most commonly, lignocaine is a local anesthetic which most commonly causes malignant hyperthermia. So with this LIG, you can remember this 3 MCQs. Okay. Now, imagine, guys, you have to give local anesthetic in a normal dose. But if you have exceeded the dose and gave it to the patient, then what will happen? There will be chances of local anesthetic systemic toxicity. Till now, are we going right, guys? Guys, are you following it? Please just write in the chat box. Are you following these things? Any thumbs up or any sign? Are you with me? Oh, goodness. Okay. Now getting some answers. Yes. Okay. Right. Okay. So whenever you give local anesthetic or any drug, you have to give in a normal, you have to give it in a normal dose. But if you exceed the dose and give it, then there will be chances of local anesthetic systemic toxicity. If at all the patient develops local anesthetic systemic toxicity, then what will happen? Which system gets involved first? Remember, guys, local anesthetic systemic toxicity first affects the central nervous system. And once the central nervous system is affected, the first sign that you see of the toxicity is what? It is perioral numbness. Perioral numbness. And now how will you treat this? If at all you have given the local anesthetic in a toxic dose and a patient had told that, doctor, I'm having perioral numbness, what could be the treatment of choice? The treatment of choice could be what, guys? You have to give 20% intralipid solution. 20% intralipid solution. Okay, very good. 20% intralipid solution. Next, coming to regional anesthesia, in which we'll be first covering for spinal anesthesia. Okay. Spinal anesthesia, what is the site where you inject or where you insert the needle? What is the site for spinal anesthesia, guys? What is the site for spinal anesthesia? It is basically the L3 to L5 site. L3 to L5 site. Any site, any space between L3 to L5, right? And you can identify the site with the help of Tuffier's line. Basically, the L4 vertebra corresponds to the Tuffier's line. Either you can go above the L4 or either you can go below the L4. You will get the site for spinal anesthesia. Now, guys, what is the needle that you use for spinal anesthesia? Will you use a thick bore or will you use a thin bore? Always remember, you use a thin bore dura separating needle. Thin bore dura separating needle. Okay, it is 25 gauge. The size commonly used is 25 gauge, thin bore dura separating needle, a thin needle, right? Next. Now, what are the orders of layers pierced by the needle in spinal anesthesia procedure? Now, this you might have gone through it in my lectures or in someone else, if you are following someone else, you might have gone through this, that layers are being pierced by your needle as you are introducing the needle from the skin. But now you have to remember this order, guys. Right. So look over here. What is the order of layers pierced by the needle in spinal anesthesia? S3 ILD mnemonic. Okay. That can also work. Just look over here. For that, I had developed a small mnemonic, guys. Whenever someone is asking you about the layers pierced in spinal anesthesia, you should always tell them, what did the patient say after spinal anesthesia? Okay. Usually patient come to me and say what, they will tell, sir, some say spinal instigates lethargy during anesthesia session. Some say spinal instigates Lethargy during anesthesia session. Now look over here, guys. Look over here. Some stands for what? The first layer to be pierced is skin. Say, S stands for what? Subcutaneous tissue. Subcutaneous tissue. Next, some say spinal. Spinal means S stands for supraspinous ligament. Next, instigates. I stands for inter or infraspinous ligament. Okay? Some say spinal instigates lethargy. Now, this lethargy is very important, guys. Why? Because this layer is very important. What is that? L stands for lethargy. L stands for ligamentum flavum. Ligamentum flavum is the toughest ligament. Once you pierce it, you will appreciate I have pierced ligamentum flavum. You will appreciate why? Because ligamentum flavum is the toughest ligament. Whenever you pierce it, you will feel a snap or sudden loss of resistance. Very, very important, guys. But you're not stopping here. After piercing ligamentum flavum, I told you lethargy during. During means dura. After you puncture dura, next is what? Arachnoid. Arachnoid. The last layer to be punctured in spinal anesthesia is what, guys? It is arachnoid. And once you puncture the arachnoid, you will be in the subarachnoid space, which will have CSF. Okay? So the order of layer is, some say spinal instigates lethargy during anesthesia session. Skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, the toughest ligament to be pierced. Okay? Then dura, arachnoid, and the dura, and the last layer is arachnoid. Okay? Once you puncture the arachnoid, you will be in the subarachnoid space, seeing the CSF. Okay? Right. Now, their next question usually is about the complication of spinal anesthesia. So, what is the most common intraoperative complication? For complications in my videos also, I have taught you with emergency drug tray, but we are not having that much of time to discuss that. So, just we are discussing in one line. What is the most common intraop complication of spinal anesthesia? Immediately after giving spinal anesthesia, what will you see in the patient? Come on, guys. What's the most common complication? Very good. Hypotension. Hypotension. And how will you treat that hypotension? By phenylephrine. Phenylephrine. The treatment drug of choice is phenylephrine. If not phenylephrine, the second best option would be what, guys? Ephedrine. Second best is ephedrine. But best option is phenylephrine. Remember, guys, I told you before giving spinal, I usually keep an emergency drug tray where I keep a drug called as phenylephrine in the first column. Second, I keep atropine. Third, I keep pethidine. Next, I keep adrenaline as well as endotracheal tube and laryngoscope. Okay. So over here, intraop complication is asking. So you just have to remember the most common intraop complication is hypotension treated by phenylephrine. What is the most common post-operative complication of spinal anesthesia? After surgery, what is the complication that you see in a patient, guys? After surgery, patient will be complaining of urinary retention. Urinary retention. Why? Because the sacral segments are usually blocked with spinal anesthesia. After giving spinal anesthesia, sacral segments are last to be recovered. Due to that, patient will have urinary retention. So what we do nowadays is we keep a Foley's catheter to avoid this complication. Now, some of you are writing headache. Remember, guys, headache or post-dural puncture headache are the same thing. Okay? Headache used to be a common complication 10 years back when we were using dura cutting needles. Nowadays, we are using dura separating needles. Okay? Sprotties or Whittaker's needles are used. Headache chances are very less nowadays. Okay? So headache is not at all a most common complication. Is it clear, guys? Right. Next, identify the needle that is being given over here. By looking at the needle, we can say, remember, this needle is having some light and dark bands. If we zoom into this needle, you can see some light and dark bands on it. What is this needle, guys? This needle is basically the, come on, what is this needle? This needle is what? This is Tuhoy's needle, which is used for epidural anesthesia, Guys, you might be knowing, those who don't know what is epidural, just look over here. Epidural anesthesia means In spinal anesthesia, you are giving the drug directly in the CSF. In epidural anesthesia, you give the drug in the epidural space. Remember, in epidural anesthesia, you are basically placing an epidural catheter and then giving the drug. Okay. So remember, epidural is used for a long duration surgeries, below umbilicus long duration surgeries. Next coming to general anesthesia. Okay. In general anesthesia, the first question is IV induction agents which are acting via GABA receptors. He's asking about IV induction agents. In IV induction agents, you are having propofol, you are having ethomidate, you have propofol, ethomidate, thiopentone, you have methohexitol. All these drugs will act via GABA, except one more drug you have, ketamine, that usually acts to the NMDA receptor. NMDA receptor. Apart from ketamine acting on NMDA receptor, as he's asking about just IV induction agents, okay, we have mentioned that these are acting through GABA receptors, and this is the drug acting through NMDA. There is one more inhalational agent that will act through NMDA, that is nitrous. Nitrous also acts through the NMDA. Okay? So nitrous and ketamine are the ones which are acting through the NMDA in anesthesia. Next, guys. IV induction of choice for patients with low ejection fraction. And again, a patient is there who is suffering with heart disease, having a low ejection fraction. Which is the IV induction you give? Remember, if you give propofol to the patient, patient will have hypotension as well as bradycardia. If you give thiopentone to the patient, patient will have hypotension and tachycardia. Okay? So you can't give these agents. Ethomidate you can give, but better than ethomidate, better than all IV induction. Remember, guys, ethomidate is good. In the IV induction agent, ethomidate is the best one. But more better than ethomidate for IV induction for low ejection fraction patient is opioid. You make the patient, you induce the patient unconscious by using opioids. Opioids are the best. Second best is always ethomidate. Second best is ethomidate. But in the question, he's asking you, given you 4 IV induction agents, and he told you which is the best one for heart disease patient, and 4 IV induction agent, he gave thiopentone, ketamine, propofol, and ethomidate. Always go for ethomidate. But if he's mentioning opioids, always remember opioids are the best induction agents used for what? For a patient who is having low ejection fraction. Now, guys, now look over here. Yeah. You know what is daycare surgery? Guys, you know what is daycare surgery, please? Daycare surgery means patient admitted on the same day, discharged on the same day. Okay? You're not keeping the patient inside the hospital for a longer time. That is called as a daycare surgery. When a patient is posted for daycare surgery, I'm just asking you guys, okay? I'm just asking you. When a patient is posted for daycare surgery, now, how will you secure the patient's airway? Will you secure the patient's airway with endotracheal tube, or will you secure the patient's airway with LMA, guys? Come on. Will you secure the patient's airway by endotracheal tube or LMA? Which one would be the best one for him? Remember, for daycare surgery, your aim should be what? Patient should have no complaints in the post-operative period. Okay? No complaints in the post-op period. If you introduce endotracheal tube, patient will have sore throat complaint in the post-op period. If he goes to his home and he's coming back in the next day and telling the doctor, I had a severe sore throat and all. Okay? So for daycare surgery, always you prefer what, guys? Always you prefer an LMA. Okay? LMA. Right? Apart from LMA, for daycare surgery, your aim is what? The patient should not have any of the side effects or any of the complications. Okay? Any of the complications means what? Usually patient after surgery will have nausea and vomiting. So you basically want the patient not to have any nausea and vomiting. You want to give a drug which is having some antiemetic property. Okay? You also want a daycare surgery patient not to have any allergic reaction. So you will try to give a drug that is antipruritic. Okay? You try to give a drug in daycare surgery, which is free from side effects causing liver disorder or liver problems. Liver problems. Okay? You try to give a drug that is not having a side effect of malignant hyperthermia. Just imagine all these scenario, guys. Okay? Right? You don't want to give a drug to this patient that causes acute intermittent porphyria. Acute intermittent porphyria. Apart from that, for daycare surgery, you also try to avoid some inhalational agents and just maintain the anesthesia with IV agents. That is called as total intravenous anesthesia. Okay? So remember, if you remember daycare surgery, you will remember all this thing. Daycare surgery patient, I'll introduce LMA, I'll give an antiemetic, antipruritic, all this. Now, why am I telling you all these things? One drug is there which fulfills all the components of this, which is the IV induction agent of choice for all of these conditions. It is propofol. It is what, guys? Propofol. Propofol is the IV induction agent of choice for daycare surgery, LMA insertion, antiemetic property, antipruritic. It is the IV induction agent of choice for liver problem, malignant hyperthermia, acute intermittent porphyria, as well as total intravenous anesthesia. So remember daycare surgery, all of these things are MCQs only, guys. It will fall. Okay? Now, so remember, for all these things, the best IV induction agent is propofol. Next, guys. IV induction agent contraindicated in head injury and neurosurgery. Come on, guys. Which is the IV induction agent contraindicated in head injury and neurosurgery? Remember, there is one IV induction agent which is usually causing problems to the central nervous system. What is that IV induction agent? Whenever you give that IV induction agent to the patient will tell, my bheja is fried. Okay? What is that IV induction agent? Very good, guys. Ketamine. Ketamine is usually contraindicated for CNS problems. Why? Because ketamine increases the intracranial pressure. It increases the intraocular pressure. Hence, contraindicated in head injury and neurosurgery. Okay? Ketamine increases the intraocular pressure. Hence, contraindicated in glaucoma. Ketamine causes epilepsy. Hence, contraindicated in epileptic patients. Okay? Ketamine causes hallucinations, hence contraindicated in schizophrenia. Okay? So basically, this is regarding what, guys? This is regarding ketamine. Ketamine. Okay? Now, which is the IV induction agent used for this procedure? What is this procedure, guys? Come on, what does this mean? What is being given to the patient? Come on, be fast, guys. This is nothing but ECT. What is ECT? Electroconvulsive therapy. Electroconvulsive therapy. And the IV induction agent of choice for it is methotrexate. Methotrexate. Very good. Okay. Next, IV induction agent causing adrenal suppression. That, remember, the IV induction agent that causes adrenal suppression is the most cardiostable IV induction agent. Which is that most cardiostable causing adrenal suppression is nothing but ethomidate. That is ethomidate. Ethomidate. Okay. Right. Now coming to the muscle relaxant topic, guys. In muscle relaxant topic, what you need to remember? Which is the shortest acting non-depolarizing? Which is the longest acting non-depolarizing? Which is the shortest and fastest acting muscle relaxant? And which is the, what are the side effects of scoline? Okay. Now look over here, guys. The shortest acting non-depolarizing muscle relaxant. When he's talking about non-depolarizing, the shortest acting is always mevacurium. Hence, it is the muscle relaxant of choice for daycare surgery. The longest acting muscle relaxant is doxycurium. Doxycurium. The shortest as well as fastest. He's not mentioning depolarizing nor non-depolarizing. He's mentioning in overall muscle relaxant category, the shortest as well as the fastest acting is choline, or we call it as succinylcholine or suxamethonium. Suxamethonium. Now, guys, remember, mention the important side effects of scoline. Now, look over here. What are the side effects of choline that we need to remember? But before going towards the side effects of choline, just look over here. If you want to remember the shortest to longest acting muscle relaxant, you can remember like this. My short dog has long tail. ठीक है? M and S, यानी कि M stands for Mevaccurium, which is shortest acting. ठीक है? D stands for Doxycurium, which is longest acting. Okay, you can remember like this. My short dog has long tail. Okay. Anyways, the shortest and the fastest is choline. So he's asking you about what are the side effects of choline. Whenever you give choline to the patient, initially it will cause fasciculation, and due to that fasciculation or rapid contraction in the post-operative period, what is the patient complain of, guys? In the post-operative period, the side effects of choline that the patient complains of is, right? The side effect is the patient will have muscle soreness. Apart from muscle soreness, what does the patient have? Patient will have hyperkalemia. Remember, choline will cause hyperkalemia due to the fasciculations and all. And the most dreadful complication, malignant hyperthermia. Remember, the most common complication is muscle soreness, and most dreadful complication is malignant hyperthermia. Malignant hyperthermia. Okay. Now, guys, a patient during surgery under general anesthesia suddenly develops a rise in EtCO2 and temperature and also muscle rigidity. All these features strike towards what diagnosis? Under general anesthesia, the patient is developing these features. Come on, guys. This gives you a diagnosis of, just now I told you, malignant hyperthermia. In malignant hyperthermia, you will see muscle rigidity. Okay, muscle rigidity. Remember, malignant hypothermia is a autosomal dominant condition. Now, what are the things in anesthesia that can cause malignant hyperthermia? There are many triggers, sir. What triggers? Lignocaine can cause malignant hyperthermia. Apart from lignocaine, choline can cause malignant hyperthermia. Apart from lignocaine, choline causes malignant hyperthermia. Remember, almost all inhalational agent causes malignant hyperthermia. Maximum incidence of malignant hyperthermia in inhalational agent, it is seen with halothane. So these are some triggers of malignant hyperthermia. If at all the patient develops malignant hyperthermia, he will have muscle rigidity. Usually this muscle rigidity starts from what muscle? It starts from the masseter muscle. It starts from the masseter muscle. Okay. And remember, malignant hyperthermia is an autosomal dominant condition. And what is the gene responsible for it? RYR1 gene. Okay. How would you diagnose this malignant hyperthermia? You will diagnose it by halothane caffeine test. Halothane caffeine test. And what is the treatment of choice or drug of choice for malignant hyperthermia? The treatment or drug of choice for malignant hyperthermia is, come on guys, I'm expecting this answer from you. It is IV dantrolene sodium. IV dantrolene sodium. Okay. So this is regarding what, guys? This is regarding the malignant hyperthermia. Okay. Now, guys, look over here. Now you have given the muscle relaxant to the patient to relax the muscle. Now, in order to reverse the effect of muscle relaxants, you have to give reversal agents. Okay, you have to give reversal agents in general anesthesia, right? So what are the reversal agents? They are cholinesterase inhibitor and they are modified gamma cyclodextrins. Okay, now remember, guys, as we are talking about cholinesterase inhibitor, the commonly used reversal agent is neostigmine. But whenever you give neostigmine for the reversal, what will happen? Patient will develop bradycardia. Due to the cholinergic side effect, patient will have bradycardia. So what we do is, with neostigmine, we either add glycopyrrolate or we either add atropine. Okay, that is the most commonly used reversal agent. Okay, and in modified gamma cyclodextrin, which is the commonly used, it is Sugamadex. And Sugamadex is commonly used for what? It is commonly used for rocuronium and vecuronium. Rocuronium and vecuronium. Okay. And remember, after giving sugamatics, there is no need to give glycopyrrolate or atropine. Okay? Cholinergic side effects are seen only with cholinesterase inhibitor reversal agent. Okay? Next. Next, coming to the inhalational agents. Now, remember, guys, in anesthesia, the work of inhalational agent is to maintain the patient in an unconscious state. Okay? He is asking you about what? Which is the least potent inhalational agent? How will you know that your inhalational agent is least potent or most potent? What indicates the potency? MAC indicates the potency. What is MAC? Minimal alveolar concentration. Minimal alveolar concentration. Okay? MAC indicates the potency. But remember, MAC and potency are always opposite. What does it mean? MAC and potency are always opposite means high MAC is equals to low potent. Okay? Any agent that is having a high MAC value, it will be low potent. Any agent that is having a low MAC value, it will be more potent. So MAC indicates the potency. Okay? Apart from MAC, there is one more thing that we need to remember about inhalational agent, that is blood gas coefficient. Blood gas coefficient is the thing that indicates how the inhalational agent will act. Will it act rapidly or will it act slowly? So it indicates the speed of onset and recovery. Remember, any inhalational agent that is having high blood gas, remember, blood gas coefficient is also inversely proportional to the speed of onset. High blood gas meaning slow onset, and low blood gas meaning fast onset. Fast onset. So anyways, coming back to our question, guys. Okay? Which is the least potent inhalational agent? The least potent inhalational agent is nitrous, which is having a MAC value of 105, very least. Okay? Which is the most potent inhalational agent? The most potent is methoxyflurane. Methoxyflurane. But again, it is not commonly used. Hence, the second most potent is halothane. Second most potent is halothane. Methoxyflurane is having a MAC value of 0.16, whereas halothane is having a MAC value of 0.7. Okay? Now, inhalational agent which is having rapid recovery and onset. Just now I told you guys what determines the speed of onset and recovery? Blood gas coefficient. So inhalational agent that is having a rapid onset and rapid recovery, it is desflurane. Desflurane. Desflurane is an inhalational agent that is having a low blood gas coefficient. Hence, it is having rapid onset as well as rapid recovery. Next, inhalational agent commonly used for induction purpose in children or induction purpose. Remember, guys, induction meaning making the patient unconscious. If you want to make the patient unconscious, the best way to make them unconscious is by IV induction. You give the drug by the IV route and the patient will become unconscious. That is the best way. Okay? But in children, as they are not allowing you to put an IV cannula, it will be difficult. So you can make them unconscious by inhalational route also. And what is a commonly used agent over here? It is sevoflurane. It is sevoflurane. Okay, guys? Right. Next, halothane features, guys. Halothane. Remember, halothane is very, very important inhalational agent that we need to remember. Halothane. First, remember, whenever anyone is asking you about halothane, 4 H's should come. Halothane start with H, right? With halothane H, you need to remember 4 H's of halothane. The first H of halothane is what? Halothane is contraindicated in heart disease patient. Okay? It is contraindicated in heart disease patient. Why? Because it causes hypotension, bradycardia, as well as it can cause arrhythmias. It increases the sensitivity of myocardium towards catecholamine, leading to arrhythmias. Okay. Second H of halothane. Remember, we have to remember 4H. Second H of halothane is what, guys? Hepatitis. Whenever you use halothane on repeated purpose, it will damage the liver cells, leading to halothane-induced hepatitis. The third H of halothane is what, guys? Hyperthermia. Hyperthermia. What hyperthermia? Malignant hyperthermia incidence is highest with halothane. The last H means what? Halothane has 2 maximums. What 2 maximums are we talking about? Halothane is the inhalational agent causing maximum bronchodilation and maximum muscle relaxation. Maximum muscle relaxation. Okay. 4 heads of halothane will cover all MCQs related to halothane, guys. Heart disease, hepatitis, hyperthermia, and halothane has 2 maximums. That is maximum bronchodilation and maximum muscle relaxation. Now coming to the most important one for general anesthesia, guys. Okay. This basically is what this is covering. Not only on 5 MCQs, 5 to 10 MCQs or 10 to 12 MCQs could be covered in this slide. Just look over here, guys. If a person is suffering with heart disease, what is the IV induction agent of choice? Remember, guys, the IV induction, everyone please listen with concentration for this slide. The IV induction agent which could be given safely is what, guys? Ethomidate. Ethomidate could be safely given in this patient, right? Why? Because ethomidate is the IV induction agent which is cardiostable. Next, which is a muscle relaxant that could be given to a heart disease patient, vecuronium. Vecuronium. Okay? So basically, you make the patient unconscious by ethomidate, you give vecuronium to the patient, and which is the inhalational agent commonly used for heart disease patient. The best is desflurane, but as desflurane is having a low boiling point, it requires a special vaporizer that is called as Tech6 vaporizer, which is very costly. Hence, we don't use desflurane. Most commonly, what we use, isoflurane. Most commonly, what we use, guys, isoflurane. Now look over here. Okay? Heart disease patient, you're using ethomidate, vecuronium, and inhalational agent is best is desflurane, most common is isoflurane. Okay? You can also remember like this. Heart enjoys very deep inhalation. You can also remember with this mnemonic. Heart disease patient, heart enjoys. Heart enjoys means heart enjoys very deep inhalation. Very deep inhalation. Just for your remembrance, guys. Okay? Enjoys very deep inhalation. Ethomidate, vecuronium, D say desflurane, I say isoflurane. Right? That is done. Now, if a patient is there who's suffering with bronchial asthma, what is the IV induction agent of choice? Basically, in bronchial asthma, your aim should be, I should give an agent that will cause bronchodilation. So the IV induction agent of choice for bronchial asthma, it is ketamine. Okay? Muscle relaxant, any muscle relaxant can be given, but avoid the muscle relaxant that will release histamine. Okay? An inhalational agent that could be given for asthma. Remember, previously it was told halothane is the best inhalational agent, but as it is causing some airway resistance, hence what we give is increase in the airway resistance. Hence, what is the best inhalational agent used for asthma? Sevoflurane. Sevoflurane. Second best is halothane. Second best is halothane. First best is sevoflurane. Second best is halothane. Now, guys, how to remember this for asthma? Always just remember, whenever anyone is asking you about bronchial asthma, just remember, asthmatic kids always seek help. Asthmatic kids always seek help. And again, asthma, you have to remember this order, guys. First, IV induction, then muscle relaxant, then inhalational. Then only this mnemonic will work for you. Okay. So IV induction, K stands for ketamine, A is any, and S stands for sevoflurane, and second best is halothane. Okay. Next, guys, shock. When a patient is in shock, he's basically having low blood pressure. So what you need to give? You need to give a IV induction agent and other drugs which will increase the patient's BP and all. So which is the IV induction agent of choice in shock? Ketamine is the IV induction agent of choice in shock. Which is the muscle relaxant of choice in shock? Pancuronium. And which is the inhalational agent of choice in shock, guys? Same like heart disease, you can just copy it. Best is Des, and most common is isoflurane. I used to remember like this. Okay, while I was studying, shock kills the patient directly and indirectly. Shock kills the patient. Kills patient directly or indirectly. Okay, the mnemonic for it is shock kills the patient directly or indirectly. Okay. Next is daycare surgery. If the patient is posted for daycare surgery, we have discussed that all points of propofol. Daycare surgery, IV induction agent of choice would be what, guys? propofol. And which is the muscle relaxant of choice for daycare surgery? Mevacurium. Even though shorter than mevacurium is scoline, but scoline is having side effects, hence we go with mevacurium. Which is the inhalational agent of choice for daycare surgery? Previously, it was told desflurane, but desflurane, as it is causing some airway irritation and causing some laryngo or bronchospasm, we are not giving desflurane. Instead, we are using sevoflurane. Sevoflurane. Okay? Now, for daycare surgery, you can remember like this. Daycare surgery, you can just remember like this. Daycare surgery patient may sleep. Daycare surgery patient may sleep. Okay? Patient P stands for propofol, M mevacurium, S is what guys? Sevoflurane. Okay? Next guys, last, neurosurgery. If the patient is posted for neurosurgery, which is the best IV induction agent? Any IV induction agent you have to give which is not increasing the ICP, which should decrease the ICP or maintain it. Okay? The best IV induction agent is always sodium thiopentone. Sodium thiopentone. Muscle relaxant, any muscle relaxant could be given over here, but you avoid scoline. Why? Because our scoline usually increases the intracranial pressure. Okay? And inhalational agent of choice for daycare surgery. Come on, guys. What is the inhalational agent of choice for daycare surgery? Come on. What is the inhalational agent of choice for daycare surgery? It is sevoflurane. Previously, it was, remember, previously it was second common is isoflurane. Now, remember, guys. Remember, previously we used to say that isoflurane is the best one. But it has been revealed that sevoflurane when compared to isoflurane, it is having low blood gas coefficient, which will cause rapid onset and recovery in neurosurgery patient. Hence, sevoflurane has become the best. Both are decreasing the ICP. Okay. So for this, how do you need to remember this? Neurosurgeons treat all safely. Okay? Neurosurgeon treat all safely. Treat all safely means neurosurgery. Treat means T stands for thiopentone, right? A stands for NE, and safely S stands for sevoflurane. So you have to remember this slide, guys. This is a very important slide. Okay? And for remembering it, I gave you the mnemonic, guys. The mnemonic is already given over here. Heart enjoys very deep inhalation. Asthmatic kids always seek help. Shock kills the patient directly and indirectly. Daycare patient may sleep, and neurosurgeons treat all patients safely. Okay, is this thing clear? Right, guys. Now coming to the next question. When is this pressure removed? First of all, what is this pressure and what is this RSI? Basically, remember, guys, any patient who is at risk of aspiration, obese patient and all, there you go for rapid sequence induction. In rapid sequence induction, what we give is we pre-oxygenate the patient with 100% oxygen. We pre-oxygenate with normal oxygen mask. Bag mask is usually avoided. Why? Because patient is full stomach. If you are forcefully pushing the air will go inside the esophagus and patient will aspirate. Okay. So first step in RSI is what? Pre-oxygenate the patient with normal mask. Bag mask is avoided. Then immediately after induction, you tell your assistant to apply pressure on the cricoid cartilage so that what is being compressed, upper end of the esophagus is closed. This is called as Selleck's maneuver. He is asking, when is the Selleck's maneuver removed? Selleck's maneuver is removed after intubation and inflation of the cuff. After intubation and inflation of the endotracheal tube cuff. There is cuff in the endotracheal tube, yes or no? That prevents the risk of aspiration. So after inflating that, then you can remove this. Okay. Now, guys, coming to this. This thing over your screen is the anesthesia machine. So I have basically pointed out two things, guys. I'll just zoom in so that you can see. Okay. So what does first pointer means and what does second pointer means? Okay. First and second pointer in the anesthesia machine, what does it mean? Okay, guys, come on. The first pointer is what? This is the anesthesia machine. On the anesthesia machine, this part is the flow meter. On the flow meter, what is the inner structure inside the flow meter, guys? Inside the flow meter, the small structure is there that indicates the flow rate, that is called as bobbin. Bobbin indicates the flow rate of the gas. And what is the second thing that I'm asking you about? The second structure is emergency oxygen flush. Emergency oxygen flush will flush out the oxygen, or it will deliver oxygen at what rate? At 35 to 75 liters per minute. 35 to 75 liters per minute. Yeah, PDF will be available, guys. No, don't need to worry. PDF will be available. Okay. Now look over here, guys. Right. Now he's asking you about color coding of oxygen and nitrous cylinder. Okay, color coding of oxygen and nitrous cylinder. All cylinders are given different color coding so that you can just look at the cylinder and tell what gas is it. Okay. For oxygen, what is the color coding, guys? Oxygen is like a bodyguard to us. The color coding for oxygen cylinder is black body, white shoulders. Black body, white shoulders. You have to remember the shoulder color different, body color different. Okay, black body and white shoulder. Whereas for air, what is the color, guys? Air, it is opposite of oxygen. It is white body and black shoulder. White body and black shoulder. Okay. Nitrous, what is the color coding? Nitrous, always remember, guys, nitrous is stored in Neela cylinder. Neela means what? Neela means in English blue. Complete blue. यानी कि blue body, blue shoulders होंगे nitrous का. Entonox. Entonox meaning what? Entonox is 50% oxygen, 50% nitrous. So it will be having blue body and what shoulder? Blue body and white shoulder. Blue body and white shoulder. Whereas carbon dioxide has gray color. Carbon dioxide, gray color. Commonly used for this, this thing, no? Inflation of the abdomen during laparoscopic surgery. Okay. Now, guys, remember, this is the color coding for the cylinders. Now, there is a central pipeline also. Just look over here. There is a central pipeline also. They are nowadays asking you about the color coding of the pipeline also. Okay. If you want to remember the pipeline color, it is very simple, guys. Just remember the shoulder color. If they are asking you what is the oxygen pipeline, always remember oxygen was black body, white shoulder. So the shoulder color of the cylinder will be the pipeline color. So oxygen, what is the color of the oxygen pipeline? White. Air pipeline, shoulder color is black, so it will be black. Okay. Nitrous pipeline, what is the color? Nitrous is total complete blue, whether it is blue body and blue shoulder. So the pipeline will be blue. There is one more pipe, guys, vacuum. For vacuum, always need to remember vacuum, the color is yellow. Okay. Vacuum starts with V, add a stroke, it looks like Y. So vacuum color is yellow. The pipeline color is yellow. Okay. Next, guys, coming to the next thing, pin index system for oxidant. There is no oxidant, such kind of thing. It is oxygen. Pin index system for oxygen and nitrous cylinder. What is pin index system? Pin index system is a thing that is preventing the wrong attachment of the cylinder to the machine, where pins are present on the machine and holes are present on the cylinder. Okay. Now, guys, regarding pin index system, for air, what is the pin index system? Air, the pin index system is 1, 5. Oxygen, 2, 5. Nitrous, 3, 5. Entonox, 7. Carbon dioxide is 1, 6 and 2, 6. But again, guys, you have to remember it. And it is my job to make you remember. So look over here. Air pin index system, when I am telling 1, 5, what does it mean? It is fitting into the first and fifth port. First and fifth port. Now look over here. They won't be asking you first and fifth port. They will be asking you pin index system. It is 1, 5. Air starts with what alphabet, guys? A alphabet. And alphabet A, alphabet A is the first alphabet. So everyone look over here. Look over here. Air, oxygen and nitrous, one thing is common. What is common? The second pin is common. 5, 5, 5. Just we need to remember the first pin. Okay? Air pin index, air, remember air starts with alphabet A. A is the first alphabet. So it will be 1, 5. So we can remember air 1, 5. Oxygen, whenever you are writing, you will write O2. So it will be 2, second pin index is always 5 only, 2, 5. Nitrous, when you are writing it, you have to remember N2O. Yani 2 molecules of nitrogen and 1 molecule of oxygen. How many molecules? 3. So it will be 3, 5. So 1, 5, 2, 5, 3, 5. This you can easily remember. Air, oxygen, nitrous. Entonox is very simple, guys. How many alphabets are there in Entonox? 1, 2, 3, 4, 5, 6, 7. So the pin index system for Entonox is 7. Whereas for carbon dioxide, the pin index system is 1, 6 and 2, 6. Okay. Is it clear, guys? Right. Now, guys, look over here. What is this device made up of? First of all, I'll show you what is this device. You have to identify what is this device. Come on, guys. Please be quick. What is this device which is being shown over here? This device is nothing but vaporizer. Vaporizer. What is the function of vaporizer? To store the liquid inhalational agent. What is being asked in this question? What is this device made up of? What is the material? This device is made up of copper. Okay, this device is made up of copper material. Now look over here, guys. All of these vaporizers, all of the inhalational agents, volatile inhalational agents are stored in the vaporizer. Okay. Now, one gas is there that requires a special vaporizer. One inhalational agent is there. Guys, you're not messaging. Your messages are being delayed. It's coming delayed. Okay. So anyways, desflurane requires a special vaporizer. Why? Because it's having a low boiling point. That vaporizer is called as Tech 6 vaporizer, which is very costly also. Now, regarding the vaporizer, remember the material is copper. Apart from that, what is the color of the vaporizer? Right. Remember, halothane, isoflurane, sevoflurane, and desflurane. What are the color of this vaporizer? It's very simple, guys. Halothane. When anyone is asking you the halothane vaporizer color, halothane, halothane, yani ki hellfire is red in color, so you need to remember it is a red color vaporizer. Okay. Sevoflurane. If anyone is asking you what is the color of sevoflurane vaporizer, sevo yani ki sevaiya. Sevaiya is yellow in color, sweet to taste, yes or no? So sevoflurane is stored in yellow color vaporizer and it is having a sweet odor. Right. Next, D stands for desflurane. Desflurane is stored in what vaporizer? In what color vaporizer, guys? Des meaning desi. Desis yani ke Indians. Indian, what is the Indian jersey color? It is blue color. Isoflurane is purple color. Isoflurane is what color, guys? Purple color. Okay. Halothane red, sevo yellow, desflurane blue, and iso is purple in color. Right. Next, guys. It's regarding the breathing circuit. Which of the breathing circuit is which is the breathing circuit of choice for spontaneous ventilation? And which is the breathing circuit of choice for controlled ventilation? Okay. Now, guys, look over here. For ventilating a patient, we need a breathing circuit. We are commonly using the Mapleson circuit. In the Mapleson circuit, they are Mapleson A till Mapleson F circuit. The circuit of choice for spontaneous ventilation is always Mapleson A circuit, which is also called as Maggle circuit. Maggle circuit. Just look over here, guys. Okay. Again, for this circuit, you have to remember SACD. SACD yani ke for spontaneous ventilation, A circuit. For controlled ventilation, D circuit. Okay, SACD. Okay, Mapleson A circuit is called as Maggle circuit, which is a circuit of choice for spontaneous ventilation. Right, spontaneous ventilation. And when he's asking about controlled ventilation, then it is circuit D, which is called as Bain circuit. Circuit D, which is called as Bain circuit. Mapleson D circuit is also called as Bain circuit, which is the circuit of choice for controlled ventilation. Controlled ventilation. Then there is Mapleson E circuit, guys. When do you call a circuit Mapleson E? When it is a bagless and a valveless circuit. This is basically an Ayers TPs. Ayers TPs. Okay? Then this circuit was modified by two guys whose name was Jackson and Reese. They added a back to Mapleson E and it became Mapleson F circuit. And this is Mapleson F circuit is the circuit of choice for pediatric cases, either for control as well as spontaneous ventilation. Okay? For control and spontaneous ventilation in pediatric, it is Mapleson F circuit. Whereas SACD is for the adults, guys. SA meaning spontaneous A circuit and control, it is D circuit. Okay. Now, which inhalational agent is avoided with soda lime due to the risk of compound A formation? Remember, guys, soda lime usually comes in a closed circuit. In closed circuit, there is this thing which absorbs the carbon dioxide. Okay, there are two structures. There are two things that can absorb the carbon dioxide. One is the soda lime, other is the bara lime. Okay, which are commonly used, guys. Soda lime and bara lime. Whenever you are using soda lime, which inhalational agents will you avoid, guys? C, T, scan inhalational agents. C stands for chloroform, you are avoiding. T stands for trilene, you are avoiding. Why? Because trilene, if you go give it in a closed circuit, it will react with soda lime and it will form phosgene and trichloroacetylene that can cause ARDS. Okay. Next, S stands for sevoflurane. Sevoflurane is also avoided with soda lime. Why they are avoided, guys? They are avoided. Why? Because remember why sevoflurane is avoided? Why? Because sevoflurane reacts with soda lime to form this compound called as compound A. Apart from soda lime, there is one more absorbing material called as bara lime. Bara lime is made up of both barium hydroxide and calcium hydroxide. And whenever you are using bara lime, three inhalational agents are avoided with bara lime. What are the three inhalational agents which are avoided with bara lime? Di-inhalational agents. If you use these three inhalation agents, patient will die. D stands for desflurane, I stands for isoflurane, E stands for N-fluorine. Why? Because when you use these agents with bara lime, they will react with bara lime to form carbon monoxide. Okay, maximum carbon monoxide can be formed with desflurane. Okay. Next, patient was posted for surgery under general anesthesia. An intubation attempt was done which has failed. Now oxygen saturation is dropping. What is the next step to manage the patient's ventilation? Yani this is the case of failed intubation. Whenever intubation is failed, what we need to do, guys? Whenever intubation has failed, the next best step is to ventilate the patient. How will you ventilate the patient? The best way to ventilate the patient, if in the case of failed intubation, is by LMA insertion. LMA. Now, guys, LMA means laryngeal mask airway. Remember, tracheostomy is not the best one, guys. If intubation has failed, put a LMA, ventilate the patient. If putting an LMA is also failed, then you go for two-hand technique, two-person technique. One person will be holding mask, other will be giving the back to ventilate. If that also fails, then you need to go for scalpel cricothyroidotomy or tracheostomy. That's the last option. Okay. Right. So anyways, laryngeal mask airway is never a definitive airway. It is indicated for what patient? If at all you are failing in intubation, in cases of failed intubation or difficult intubation, you go for it. Contraindication, remember, laryngeal mask airway is kept in the supraglottic area. Hence, you will be ventilating the trachea as well as the esophagus. Hence, the gases will enter the esophagus also. So contraindication will be what? In a full stomach patient, you cannot put an LMA. Or if the patient is having any blood in the oral cavity, you cannot put the LMA, blood in oral cavity. Okay? Why? Because if at all you are putting an LMA, you are pushing the blood into the trachea. That will cause aspiration. Now, in this LMA, depending upon the ports, there are two types of LMA. First generation and second generation. Just look over here, guys. Single port. These are the common generations. There is third generation also, but you have to remember first generation LMA is a single port LMA, right? Single port classical LMA. Whereas if you add an additional gastric port, which is used for deflating the stomach, through which you put a Ryle's tube, then there are many LMAs in the second generation. There is LMA Pro Seal, there is LMA Supreme, there is iGel. Now you don't have to confuse yourself. Sir, where in the iGel there are two openings? There is only one opening. No, one more opening will be here, guys. One more opening will be located here. So iGel is also having two openings. Apart from that, streamliner of pharynx, which is called as SLIPA, also comes under second generation, and Ambu, Gain, LMA. These are all second generation. There was a question which was asked in the INI-CET or NEET, I don't remember, but there was of Ambu Aura LMA. Ambu Aura LMA is the first generation LMA. Okay. So anyways, guys, these are regarding what? These are regarding the laryngeal mask airway. Now, guys, for endotracheal intubation, you keep the patient in a sniffing morning air posture. In sniffing morning air posture, what is the sniffing morning air posture? In sniffing morning air posture, where is the extension? Where is the flexion? He's asking. Basically, he's asking where is the extension? Come on, guys. Sniffing morning air posture, where is the extension? You give extension at the atlanto-occipital joint and flexion at the cervical spine. This is the sniffing morning air posture, guys. Extension at the atlanto-occipital joint and flexion at the cervical spine, so that the oral and pharyngeal axis is at the correct line and you can easily see the vocal cords. But remember, this position is used for all intubation cases except obese. All intubation cases, this position. But for obese patient, you have to use rammed position, rammed up position for obese patient. Then only you can see the vocal cords easily. Okay. Next, guys. Imagine, guys, you are intubating. Now, you take a laryngoscope. He's asking you which laryngoscopy blade will you use in pediatrics. There are two blades in front of you. This blade is called as Macintosh laryngoscope. This is called as Macintosh laryngoscope and this is called as Miller's laryngoscope. Come on, guys. Which one could be used in pediatrics? In pediatrics, as they are having large epiglottis which can be easily lifted with a straight blade. In pediatrics, always the answer is what, guys? The answer is Miller's laryngoscope. Miller's laryngoscope. Macintosh can be used for adults. Okay. Macintosh. This is Macintosh, which is used for adults. Okay. Now, while intubating, while lifting the tongue, now you see the vocal cords. Now, when you see the vocal cords, based on the appearance of vocal cords, there is a classification given, which is called as Cormack-Lehan classification. That Cormack-Lehan classification, in grade 4 Cormack-Lehan, what do you see? If you want to answer this, first we need to understand the 4 grades of Cormack-Lehan. Okay? So while lifting the tongue, if you see the whole laryngeal aperture, whole laryngeal aperture, यानी कि epiglottis, vocal cords, arytenoids, that is grade 1. Grade 2 means if only posterior portion of laryngeal aperture is seen, that is grade 2. Grade 3 means you're only able to see the epiglottis. And what is grade 4 means, guys? Grade 4 means epiglottis is also not seen. Epiglottis also not seen. That is called as Cormack-Lehan classification. Okay? Right? Next. Regarding the endotracheal tubes. Guys, remember which endotracheal tube are we commonly using? Are we using, before going to this question, guys, just answer one small question. Which endotracheal tube are we most commonly using? Are we using like a low pressure, high volume or high pressure, low volume? Low pressure, high volume or high pressure, low volume? Come on, guys. Always remember the endotracheal tubes which are commonly we are using is PVC tubes which are low pressure, high volume cuff. Okay? Previously we were using high pressure, but now we are low pressure. So endotracheal tube of choice for one lung ventilation. Which endotracheal tube is given for one lung ventilation? Second question is endotracheal tube of choice for oral cavity surgeries. The third question is endotracheal tube of choice for prone position. Just look over here. Look over here. So these are the 3 options over here. A, B, and C. First tell me, guys, among these 3, which is the endotracheal tube commonly used for one lung ventilation? A, B, and C. Which is used for one lung ventilation, guys? For one lung ventilation, always remember you use a double lumen tube. Double lumen tube. Okay, double lumen tube is used for one lung ventilation. Okay. Now, next question, boss. Which is the endotracheal tube commonly used for oral cavity surgeries? For oral cavity surgeries, we use a ray tube. This is the endotracheal tube which we put through the nose. If there is a surgery on the oral cavity, you cannot put the tube through the oral cavity. You have to put through the nose into the trachea. So this is called as raised tube, and which is the tube commonly used for surgeries done in prone position. In prone position, you use a flexometallic tube. Flexometallic, why we use? Why? Because no matter how much you turn the patient, if at all the tube twist also, there won't be any kinking. Okay, for prone position tube, you are using this flexometallic, or it is also called as armored tube. Okay, armored tube. Next, guys. The exact size of this airway is determined by keeping it. Remember, this is the nasopharyngeal airway. And nasopharyngeal airway, how the exact size can be determined? You keep the airway between the nose and the tragus. You keep the airway between the nose as well as nose and tragus. There is one more airway apart from this, which is called as Goodell's airway. Goodell's airway. Remember, guys, this is nasopharyngeal airway and this is Goodell's airway. Remember, nasopharyngeal airway is contraindicated if the patient is having base of the skull fracture or any bleeding disorder. Any bleeding disorder. Okay. The second airway is called as Goodell's airway. Goodell's airway you keep through the oral cavity. How will you know the exact size of Goodell's airway? Keep it between the tragus of ear and angle of mouth. Tragus of ear and angle of mouth. Next, guys, AMBU bag. What is AMBU? Full form of AMBU is artificial manual breathing unit. Okay? In AMBU bag, there are two valves. One is the unidirectional valve, other is the pressure relieving valve, usually that you see in adult AMBU bag. Okay? In the pressure relieving valve, it can relieve a pressure of up to how much? 30 to 40 centimeters of water. 30 to 40 centimeters of water. Okay. Now, guys, look at this and please tell me answer for this question. What is the next step when you see this capnograph on your screen during surgery under general anesthesia? You are doing surgery and you are seeing suddenly the capnograph is appearing like this. What does it mean? And what is the next step? Come on, guys. I need answer from you on this. Please. Very good. Deepen. How will you deepen the plane of anesthesia? You're telling me to deepen the plane of anesthesia. How? Remember, first of all, guys, just look over here. Look over here. Right. Before solving that, just look over here. Okay? Capnograph is nothing but graphical representation of carbon dioxide, which is usually having 4 phases. What is the first phase? First phase is called as inspiratory baseline. Inspiratory baseline. The second phase is called as expiratory upstroke. Expiratory upstroke. The third phase is called as alveolar plateau. And fourth phase is called as inspiratory downstroke. Now look over here. There is an angle between phase 2 and phase 3, which is called as alpha. There is an angle between phase 3 and phase 0, which is called as beta. Capnograph is measured best at this angle. It is best measured at this angle. Capnograph value comes usually at this angle, beta. Okay. So anyways, this is the normal capnograph that you see. But in this case, you have seen there is a notch developing. If you see a notch developing, that means what? Development of a notch means the patient's respiration, spontaneous respiration has once again begun. Yani ki patient was undergoing surgery. Now he is breathing spontaneously. What is the next step? You need to deepen the plane of anesthesia. Yani ki you need to give muscle relaxant. You need to give muscle relaxant. So answer for that is what, guys? You have to give muscle relaxant. A top-up dose of muscle relaxant has to be given. Okay, that's regarding what? That's regarding the capnograph. There are various capnographs, guys. Okay. Yes, it is a curar cleft or notch. Okay. Now, there are many kinds of capnograph. We'll go to it. We can't go through each of them. Next question, guys. which low flow oxygen device can give an FiO2 of 25 to 45%. Now, guys, remember, imagine, first, before answering this question, imagine you are in the emergency room, okay, and you get a patient who comes with an oxygen saturation of 85%. His his breathing pattern is normal. His breathing pattern is normal, but he is having a saturation of 85%. When I see this patient, what will I do is, I first apply a low flow oxygen device to this patient. What is the first low flow oxygen device which I apply to the patient? That is called as nasal prawns. I apply the nasal cannula. Okay? Why am I applying nasal cannula? Why? Because with nasal cannula, I can give 1 to 6 liters of oxygen that will supply 25 to 45% of FiO2. Okay? If at all he is not improving, then I'll tell, please bring a simple face mask. A simple face mask is the second step. Okay? Simple face mask. Simple face mask, we can supply how much of oxygen with simple face mask? Remember, with nasal cannula, 1 to 6 liters of oxygen, which will give an FiO2 of 25 to 45%. If he is not improving, then simple face mask. Simple face mask, 6 to 10 liters of oxygen can be given, which will give an FiO2 of 35 to 60%. Simple face mask. If he's still not improving, I will tell his attender, please bring a non-rebreathing mask. Non-rebreathing mask looks like this, guys. The third is this NRBM, non-rebreathing mask. In how much of oxygen will be supplied? 10 to 15 liters. You get this point? We are slowly increasing the flow rate of the oxygen so that his saturation comes up. And how much of oxygen this will supply? 65 to 95% of FiO2 can be supplied. If still not improving, what will I tell? By these three masks are not improving. Now, please bring a high flow device. In high flow, there are two types. One is called as a Venturi mask. Remember, Venturi mask, you will be having some colors of this mask, guys. Venturi mask. Based, if at all, in the MCQ, they have given you mask with colors. That is usually the Venturi mask. Venturi mask will supply 2 to 15 liters of oxygen that will give an FiO2. We can achieve an FiO2 of 24 to 60%. Okay. Last is, if the patient is not improving, then you can go for high flow nasal cannula. High flow nasal cannula will give 40 to 60 liters of oxygen, which will supply 100% of FiO2. This is regarding the oxygen delivery devices. Okay? Low flow oxygen delivery devices are these three, whereas high flow oxygen delivery devices are the Venturi mask and the high flow nasal cannula. That we have to remember. Okay. Now, if still the patient is not improving with HFNC, then you can go for a ventilator. Now, in the ventilator, there is a question, guys. In which mechanical ventilator mode is preset tidal volume delivered? Okay. First of all, guys, remember, mechanical ventilation is of two types. Mechanical ventilation is of two types. Mechanical ventilation is of two types. One is called as a non-invasive, other is called as an invasive ventilator. Invasive ventilator. Okay. Now, imagine, guys, a patient is there who's not improving by HFNC, then what will you do? First, you will, if at all, the patient, remember, for non-invasive ventilation, the mandatory criteria is patient should be conscious. That is the mandatory criteria. Patient should be conscious. Pardon my spellings, guys. Okay? Patient should be conscious. Now, remember, if the patient is unconscious and if you apply non-invasive, the patient will aspirate. In non-invasive, again, there are two types. One is called as CPAP, other is called as BiPAP. CPAP means continuous positive airway pressure, and BiPAP is nothing but it gives two levels of pressure. One is the inspiratory, other is the expiratory. Take a higher inspiratory and a lower expiratory pressure. Remember, both of these non-invasive are usually used for COPD patients and some other minor conditions. But if the patient is having mild COPD or if the patient is having mild hypoxemia, you can go for CPAP. But if the patient is having severe hypoxemia, you can go for BiPAP. But if you feel the patient is now becoming drowsy, unconscious, or his ABG is showing a high carbon dioxide, which is indicating towards the patient might undergo into CO2 narcosis, then you have to go for invasive ventilator. Invasive ventilator, guys, remember in invasive ventilator, there are 5 important modes that we need to remember. What are the 5 important modes of invasive ventilator? First mode is called as continuous mandatory ventilation. Continuous mandatory ventilation. Second is called as assist control mode. Assist control mandatory ventilation, which includes volume control and pressure control. And the last ones are the spontaneous modes, the spontaneous in which you are having pressure support and SIMV. Now, guys, look over here. When a patient is, I'll just give you a scenario and quickly I'll explain the ventilator modes in 5 minutes. Okay? So look over here. If a patient meets with a road traffic accident, okay, and he's not at all breathing, he's in a gasping state, he's brought to the casualty. What you will do, you will keep the patient, you will intubate the patient and keep him on ventilator. Now, in this 5 modes, which is the mode that you initiate, patient is not at all breathing. When patient is not at all breathing, you want your ventilator to do all the job. You want your ventilator to do, you adjust the tidal volume. You want the ventilator to deliver a pressure also. So remember, ventilator, if it is generating a tidal volume and it is keeping the pressure, it is controlling the pressure, then it means what? It is a continuous mandatory ventilation. Remember, guys, remember, if ventilator is generating tidal volume as well as it is generating pressure, yani it is controlling all 2 components, then it is called as continuous mandatory ventilation. It's basically like, imagine, guys, you know, Tesla car, you like if you sit in a Tesla car, it is a driverless car, AI generated and all. You will be sitting at the back seat. The car will take you to your destination. Are you driving? No. Continuous mandatory ventilation is also like a Tesla car. Why am I telling it like a Tesla car? Why? Because in continuous mandatory ventilation, patient has to do nothing. He doesn't have to breathe. Nothing has to be done. He just have to sit and relax. The ventilator will take care of his tidal volume and the pressure. But the ventilator wants the patient to be in a relaxed state. Hence, what we give? We give the patient heavy sedation. And as we are giving heavy sedation to the patient and all, the patient is not breathing and the ventilator is giving the volume as well as pressure. But due to this, what will happen? Guys, if you are in a Tesla car, if you go to and fro by the Tesla car only, what will happen to you? You become lazy. Same on this mode also, patient becomes lazy. He does not use his muscles. And due to that, what is the side effect that you see of this mode? You will see atrophy of the muscle. Patient will have muscle atrophy. Okay, so continuous mandatory ventilation, it is the ventilator controls the 2 things together, tidal volume and the pressure. Assist control is of 2 types, guys. Assist control means volume control and pressure control. Now imagine the same patient is improving. If he is improving, then slowly we'll cut down the CMV and we go into the ACMV. ACMV is a step down mode of CMV. Now what we'll do? We will give the patient a chance to breathe. We are giving a chance for triggered breathing. But why are you calling it as a volume control? When you are controlling the volume, what is the controlled variable over here? The controlled variable over here is volume. Control variable is volume. Yani you are giving the tidal volume. Ventilator is just generating the pressure and giving it to the patient. Okay? But patient trigger breathing is allowed in volume control. But as you are allowing the patient triggered breathing, what will happen? Sometimes the patient will be breathing, sometimes the ventilator is breathing. There will be asynchrony in this mode. And due to this, what will happen? The patient's respiratory rate might increase, which will lead to hyperventilation that can lead to respiratory alkalosis. Okay? Again, here also sedation is required. But how sedation is required? Moderate sedation is required. Moderate sedation is required in volume control. Okay? In ACMB, the other mode is what, guys? Other mode is pressure control. Pressure control means what is the control variable over here? It is the pressure that is the control variable. Okay? Pressure is the controlled variable. Okay? Again, here also a moderate kind of sedation is required. Then if the patient is like a patient primary like patient vital parameters are improving, ABG is improving, then you can go for a more step down mode, which is spontaneous mode. In spontaneous mode, you are having pressure support and SIMB mode. Okay. Apart from these modes, there is one more thing that we need to remember. In the ventilator, we also adjust a PEEP. What is PEEP? PEEP is nothing but positive end expiratory pressure. Okay, positive end expiratory pressure. Why do you adjust it? Why? Because it will improve the oxygenation. It will prevent atelectasis. Okay, and it reduces the work of breathing. Commonly used for ARDS and pulmonary edema. But remember, guys, whenever you increase the PEEP value, positive end expiratory pressure value, what will happen? The venous return decreases, the cardiac output decreases, and patient will have hypotension. So remember, if the patient is having a patient is in shock-like condition, their PEEP should be avoided. Okay, side effect of PEEP is it can cause decreased venous return. So hence contraindicated in shock, and PEEP also increases the intracranial pressure. So it should be avoided in head injuries. Head injuries. Okay, just a brief review I'm giving, guys. Okay, ventilator itself is a big topic, 1.5 hour topic at least to get the concepts clear. Okay. Next, guys, a patient suddenly collapses. What is the immediate next step to save his life? Come on, guys. We are running out of time. Please answer. If a patient suddenly collapses, what is the immediate management? The next best management to save this patient life. Remember, we are talking about the basic life support. First best step is what? It is always the scene safety. You have to look whether the scene is safe or not. Then you can go for what? Then after scene safety, you need to check for the response. Then if there is no response, no. There is no risk of respiratory alkalosis in pressure control mode. There is a risk of respiratory acidosis in pressure control mode. Why? Because the volumes, remember in pressure control mode, we are just adjusting the pressure. The ventilator is generating the volume. Sometimes the volumes might not be generated up to the patient requirement. Due to that, patient might have respiratory acidosis, not alkalosis. Only in one mode you will see respiratory alkalosis, that is volume control. Okay. So anyways, guys, we are talking about the steps of BLS. Remember, the first step is scene safety. The second step is check for the response. If the person is not responding, there is no response, then you call for help. Okay. Then after calling for help, you check for the pulse and breathing. Which pulse are you checking? Carotid pulse. Okay. In infants, you check for the brachial pulse. Then last is, if there is no pulse, no breathing, that is a cardiac arrest state, you start your CPR or CPCR. The sequence of BLS is SCCS. Scene safety, check for the response, call for help, check for the pulse and breathing, and last is start your CPCR. Okay. When we are talking about CPCR, always remember you go with CAB protocol. C stands for compression, A stands for airway, and B stands for breathing. Okay. CAB protocol. Okay. CPCR is started with CAB protocol. It's not ABC, CAB. So look over here. Now, regarding compressions, how many compressions should be given? 100 to 120 compressions in 1 minute. What is the depth of compression? Each compression should be at least 2 to 2.4 inches or 5 to 6 centimeters, not more than that, guys. Okay. In infants, what is the depth of compression? 1.5 inches, whereas in pediatrics who are more than 1 year, 2 inches of depth should be achieved. What should be the ratio of compressions, guys? After every 30 compressions, 2 breaths. 30 compressions, 2 breaths. 32. Yani in 1 minute, you have to give 4 sets of 30:2. Then only you will achieve this. Okay. And you have to allow a complete chest recoil. So this is regarding the compressions of CPR, right? So remember, guys, the question over here, answer over here is scene safety. Next, a patient has a pulseless VT. What is the next thing? Pulseless VT, how did you know? You had connected a defibrillator. With the defibrillator, you are just diagnosed that the patient is having pulseless VT. In cardiac arrest, if you see no pulse and still ventricular tachycardia, the next immediate management is to deliver the shock. You have to deliver the shock through a defibrillator. Okay? So this is basically the ACLS algorithm. Okay? There is adrenaline. Remember, the drug of choice for ACLs for cardiac arrest is adrenaline. And there is a concentration of adrenaline that is used in cardiac arrest. There have been questions on it. Concentration of adrenaline in cardiac arrest is 1:10,000. Whereas in local anesthetic, the concentration is 1:2 lakh. Whereas in anaphylaxis, it is 1:1,000 concentration. Okay, right? Coming to the last topic, which is called as monitoring in anesthesia. Now, guys, look over here. Whenever the patient is in anesthesia, what are the things you monitor for? There are some monitors which are mandatory monitors. In the mandatory monitors, you have to monitor the patient's oxygenation by pulse oximetry. Pulse oximeter works on Beer-Lambert's law. Okay. Next, ventilation. Ventilation can be monitored by capnography. Capnography. Okay. If the capnograph value is good, then you are adequately ventilating the patient. Okay. If it is decreasing, that means you are not ventilating the patient. It is hypoventilation and all. Okay. There are different forms of capnograph. Circulation, how it can be monitored by BP. In BP, you're having invasive and non-invasive. In invasive, what is the artery that you use? Commonly, we use a radial artery. Okay, but before going for radial artery, invading the radial artery, you go for an Allen's test to know the patency of the radial artery. Okay. So anyways, BP is there, ECG. In ECG, there are two leads which has to be monitored. Lead 2 and lead 5. Lead 2 monitors arrhythmias, lead 5 monitors ischemias. Okay? Then there is a sophisticated monitoring that is called as transesophageal echocardiography, T. Remember, transesophageal echocardiography is nothing but you put an echo probe and insert from the mouth into the esophagus and you scan the heart. That is called as transesophageal echocardiography, which is commonly used to diagnose embolisms, venous air embolisms. Okay. Next is temperature monitoring. In temperature, you can monitor the peripheral temperature and core temperature. The best site for core temperature monitoring is pulmonary artery. And how will you monitor the core temperature of the pulmonary artery? By Swan-Ganz catheter. Swan-Ganz catheter. Okay. Apart from that, some desirable monitors are also used according to the patient's surgery. Okay. If the patient surgery is for a longer time, you can also go for awareness monitoring, whether the patient is aware or not. For awareness monitoring, you can go for BIS. What is BIS? Bispectral index, which calculates the sum of electroencephalograph, EEGs. Okay. Last is neuromuscular monitoring. In neuromuscular monitoring, there are many monitors. There is train of 4 monitor, there is single twist, there is double burst, but most commonly we use what? Train of 4 monitor. Train of 4 monitor. Okay. For neuromuscular monitoring. Okay. The last slide over here, guys. Come on. What is being done in this picture? In this picture, IVRA is done, which is Bayer's block. Bayer's block. Bayer's block यानी कि tourniquet is applied on the hand, and on the same hand you are applying a cannula and giving the drug. Most common local anesthetic that is used in Bayer's block is lignocaine. Okay, and IVRA or Bayer's block is lignocaine. Okay. Now, regarding that, what we need to remember is what is the pressure. Remember, first of all, IVRA is used for what surgeries? Limb surgeries, whether upper limb or lower limb surgeries, right? Which are done within 1 hour duration. So if at all upper limb you are applying a tourniquet, upper limb the muscle mass is less. So you apply less pressure to occlude the blood supply or occlude the passage of the drug to the upper side. So remember, the pressure applied in the upper limb is 50 plus systolic blood pressure. For upper limb, it is 50 plus systolic blood pressure. Whereas in lower limb muscle mass is very much. So you need to apply much pressure to occlude the blood vessels. So what is the pressure? 100 plus systolic blood pressure for lower limb. This is regarding the IVRA, intravenous regional anesthesia. Okay, guys. So these were some important points, guys. I hope you're doing well. Okay, these were some important points. Again, this cannot replace the whole anesthesia thing, but again, this is the most important, like I try to cover the most important topics as well as almost all topics of anesthesia in it. Okay. Any doubts regarding the ventilators? Because what I found is students are having some things about ventilators, some doubts about ventilators and all. Ventilator topic is clear. Anyways, it will be on YouTube. You can again go through it. Remember, if the patient is not at all breathing, you go for CMV. That is a mandatory. CMV mode is a mandatory mode for ventilation. Then ACMV. In that, you are having volume control and pressure control. Then step down, then ACMV is spontaneous mode, pressure support and SIMV mode. Okay. Okay, guys. Is it clear? Till now, is it clear? Please write anything. I'm not able to get any of your messages over here. Are you not typing? Thank you, Ram. Thank you. Any great session is not possible without a great audience. So, thanks to you also. Okay. So anyways, guys, so these were the important topics. Whichever exam you are preparing, all the very best. Thank you. Thank you. Right. All the very best. Right. So if you are having any doubts regarding any things, you can connect me with on my Instagram ID, which I have given over here. Right. We'll be connected over there. Okay, guys. So should I log off? Because I'm not getting any of your messages. Okay. Okay. So anyways, guys, all the very best. All the very best. Charan, thank you. Srini, thank you. Ram, thank you. Okay. All the best, guys. I'm logging off.